he's got years and years of experience here. And I see that he actually brought the topic that I asked him to bring tonight with post-traumatic stress disorder. And the reason that I asked him to bring up this particular topic is because I believe it is hit on the P2 final exam right now. And it's not really well talked about, not in content, not in textbooks. It's just not enough information on PTSD out there. I will be honest, my middle son suffers from severe PTSD from his lovely days in the first year of the Iraq War, cavalry scout in lovely downtown Baghdad. And he has never gotten over it. He still has night terrors, and he still says he finds himself in the shower suddenly just in tears, and this has been years. And so we as pre-hospital providers sometimes run into these patients. They may have called, or someone called 911 for something totally non-related PTSD, or it could be something that is a behavioral crisis related PTSD. But either way it goes, we need more information on this as pre-hospital providers. And so I asked Dr. Phillips to pull this lecture together specially for you guys tonight. So that having been said, I'm going to turn this over to you, sir.
All right, thank you. So first off, I'm going to tell you that we're going to look at this primarily as the provider coming up on a patient. I purposely have done it in that particular manner. We're also going to obviously address the elephant in the room as well. So we'll go ahead and just go ahead and dive right into this. At the end, there are a lot of resources that Jane, that last slide, once we get that done, if you can maybe send that out to everyone, that would probably be a great resource for them to have just tucked away. So if I can find my cursor, there it is. Okay. So PTSD, what is it? First off, it's a syndrome that results from exposure to a real or threatened death, serious injury, or sexual assault. So very specific. And it's associated with this comorbidity like Jane was talking about, functional impairment, and an increase in mortality with suicidal ideations and attempts. So let's talk about the symptoms, okay? Because we're going to get into some really heavy stuff that, frankly, isn't that useful to us in the field. It's not even that useful to me in the ER. But just to kind of give you some idea of some of the things that you should be looking for. So symptoms, first off, the biggest one is a lot of people will say that they re-experience that traumatic event over and over and over. They have intrusive thoughts. They have nightmares like Jane was talking about. Flashbacks are very common. And dissociation or detachment from oneself or reality. And so, you may have a partner or somebody that they zone out for a while, and that may be one of the signs. They have intense negative emotional status, and that's usually in the form of either sadness or guilt. And it's a physiologic reaction on being exposed to the traumatic reminders. And those can take a lot of different forms. List of additional symptoms: problem with sleep and concentration. They're irritable. They have increased reactivity. So in other words, things just that otherwise were normal, just set them off. A kid may track mud in the house and they just go off on them. They have an increased startle response. So, everyone tends to get patriotic around 4th of July, but for especially the veterans, a lot of them, that's actually a very terrifying time to them because they do have this increased startle response if they have PTSD. They're hypervigilant. I'm sure that we've seen some of the movies. I'm trying to remember the one that I saw recently where the guy is sleeping with a gun because he is just hyper vigilant. And it was about the Iraq War. Avoidance of traumatic triggers. So they may avoid things that they're fearful of that may cause them to relive some of those events. Very common. And there's significant impairment in social, occupational, and other areas. So it may be the family, it may be that they withdraw and they no longer want to go out and have, times with friends and things like that. Anyone have any questions about those symptoms up to this point? I know that's a long list of things, and I don't expect you to necessarily know every little detail, but it's more a matter of get somewhat familiar so that you can recognize these things. So we'll just start at the first here. Ryan, do you have any comments or questions up to this point? You can unmute or chat, either way is fine.
No, we do get to see quite a bit of that out here, especially with our female transit population, it seems. A lot of them have had bad sexual encounters, and they associate our lights and sirens with those encounters. So
Sure.
I think we're coming more aware of it too as we repetitively run on those individuals.
Sure. Okay. So etiology. Obviously, there can be many factors that are associated with this. First off, the biggest thing is a severe threat of or an actual injury. So a lot of folks that are in somewhat traumatic situations, such as even responding to a call and having a car accident en route to a call, may be a trigger for some people. Usually we think about near-death experiences, but it doesn't have to be that way. I have vivid recollection of one of the SWAT officers when I was in Missouri that we made an entry and he was on point. And he said that as he was coming into the living room of this house, he saw the perpetrator and his girlfriend sitting on a couch watching TV. And the perpetrator reaches across his own body to pull out a sawed-off shotgun from between the wall and the couch. And he said, I was on my MP5, I was squeezing the trigger as I saw the gun fly out of his hand and I let go. And that was a very traumatic experience for him. He had killed in the line of duty one previous time, and he was also one of our snipers. So, that was one of the things that he was very trained to do. But I still remember after the call was over, him sitting in the van while we're waiting to leave, holding the shotgun round and just staring at it. And so, there's an example of a near-death experience. So I'm sure that, firefighters, of course, go through the same sort of things. It happens often. Combat-related trauma, obviously, in the military is a big factor, but it doesn't have to just be military. It can be, hand-to-hand combat in the street even. Sexual assaults, big thing like Ryan was telling us, interpersonal conflicts. So this can be, a battered spouse. So they're having some conflict there within their relationship. Obviously, child abuse, medical illnesses, even severe medical illnesses. We're seeing a lot of folks that are having some PTSD-like symptoms after COVID-19. So the risk factors. So just because you get exposed to those things doesn't mean that you're going to have PTSD. But in general, females are more affected than males. They have a history often of childhood problems, childhood traumas, things like that. A big number have pre-existing mental illness. And when we say that, I don't mean that they're psychotic, schizophrenic, things like that. It can be simple depression. So I hate to say simple, but it can be something as common as depression or anxiety. Low socioeconomic status tends to play a part, low education, and poor social support. So if they don't have a lot of friends, if they don't have a lot of people that are around them to try to help them through these situations, those are the ones that tend to have problems. So of course, we really want to look at all of these things from a large global perspective. So epidemiology. So the traumatic event prevalence is anywhere from 61 to 80% of the population is going to have some sort of traumatic event that they're going to be involved in sometime in their life. That sounds like an awful high number, but understand that it's not necessarily directly to them that the trauma is occurring. After trauma, only 5 to 10% of those people will go on to have PTSD. So it's not a high number overall. Now, the pathophysiology I thought was actually very interesting when I was researching this, because I have never really seen a lot about the pathophysiology. So it's alterations, though, in the neurotransmitter and neurohumoral functioning. And here we're talking about cortisol. We've talked about that somewhat in the past related to stress. Then elevated levels of corticotropin releasing hormone. So, there are two things there that are stress responses. And as the CRF stimulates the release of norepinephrine, it leads to an increase in the sympathetic response. So higher heart rate, blood pressure, and especially that startle thing. So, if you think about, you've been on a roller coaster or some kind of a thrill ride or something, after that's over, because you still have that adrenaline rush, and it's not just epinephrine, it's also norepinephrine. If somebody comes up and just taps you on the shoulder, a lot of times you jump with that. That's what we're talking about. So it's all of those things together. But rather than it just being a roller coaster ride where now it's over, this is something that is a chronic sort of thing. That also leads to a decrease in GABA activity and an increase in glutamate, and that fosters that dissociation and derealization, so they don't feel that things are real. This also then leads to serotonin decrease, and then eventually you end up with actually having changes to the neurophysiology and the actual anatomy of the brain. So there are changes physically to these people's brains. The hippocampus shrinks, that's the linkage between the two sides, and the amygdala is overactive, and that produces emotions and modulates the fear. So there's a lot of things going on. And you also end up with the prefrontal cortex that is smaller and is less responsive. And that's where you have inhibitory control over your emotions. So once again, these are the areas where when people have strokes and traumatic brain injuries, we end up with these people that they don't have emotional control anymore. Well, PTSD can induce the same thing. It's obviously on a different level. It's not to the same level as somebody that had a gunshot wound to the head or something, but over time, it can turn to that. Any questions to this point? That's been like drinking from a fire hydrant already, I know that. So John, do you have anything?
Yeah, I wish I had more questions. This is super interesting for me. I've had a brief experience working in the field, but I know as career goes on, this is going to be something really important for me to understand. So I guess one thing, I think you kind of ended up saying this, but the changes in the neuro and brain anatomy, is that happens over probably a pretty long period of time, right? Or is that,
Right.
I mean,
No,
how
it
quick does that
doesn't
happen?
happen. Well, I didn't find anything that gave a good time frame, but my guess is
Gotcha.
that it's probably, we're talking about 5-10 years or more.
Right. Okay.
And so and we'll talk more about the duration of some of this stuff later on, especially at the very end of this lecture, but it's an
Okay.
excellent question. I appreciate you asking that. That's a very, very interesting thing. And like I said, I hadn't seen this before. So,
Right. Okay.
and just to throw it out there for everyone, almost all this information was gleaned from a few sources, but especially Stat Pearls, and I've told you that I like that particular source in the past, and they do have an emphasis on EMS in some of their topics, but it's an excellent source. It's through the National Library of Medicine. You can just Google Stat Pearls, all as one word, and then whatever your topic is. And if there's one there, it's going to pop up. So I would definitely recommend that you take a look at that.
All right. Will do. Thank you.
All right. So the H&P, I've told paramedics, medical students, everyone over the years that regardless of what you go into in medicine, you're going to be doing histories and physicals for the rest of your career. You might as well just go ahead and start enjoying it and get good at it. So in this case, you're going, hold on, PT, how can I do a history and physical on that? Actually, you can. Okay. First off, the history is going to be the really, really important part of this, because unfortunately, a lot of times these folks don't want to share this stuff. And it's not our place to go in and pull it out like a tooth that needs extracting. But it is our place to give them the okay, the permission to speak about this stuff, and to, even if they don't talk to anyone right now, to give them the information that it is safe to talk about this, to help to break down those walls. But you do need to, if you know that there was a traumatic event, talk to them about that. Try to get their opinion about how bad it was, what was the severity, and obviously with any symptoms of presentation and duration, the OPQRST, and then this in particular, that last point, depression, anxiety symptoms, suicidal ideations, previous attempts, substance abuse, and access to firearms. I ask about suicidal ideation on a pretty regular basis. And the way that I typically word that particular question is, have you had any thoughts now or in the past of ever hurting yourself in any way or trying to kill yourself? It's a very open question, and there's no judgment in that. And then the next question is worded very similarly. Have you ever now or in the past had any thoughts about hurting or killing anybody else? And if they say that they have had those, the next follow-up question that I always ask is, okay, well, if you were going to hurt or kill yourself, how would you do that? And sometimes the answer is, I really don't know. I try not to think about that. Sometimes the answer is, oh, I've got a bullet set aside. Do you have a gun? Yeah, I have a gun. Okay. And the next part of this, very important. And I try to tell people when they're taking a history to always do this. Thank them. It's a simple gesture, but it opens them up so much more if you just simply go, thank you for sharing that with me. I know that had to be kind of sensitive, or it may have been hard for you to tell me about, but I really need to know those things. Thank you. So Ben has a question about brain changes. Well, you're definitely talking to the wrong person about evolutionary biology. I really don't know the answer to that question. I'm not sure that, certainly the prefrontal cortex would be one of those affected, but from an evolutionary perspective, that part of our brain was the last one to be developed. So I guess if you're saying that it takes you back more to a reptilian sort of brain where it's, reactionary rather than reasoning, then I think you're probably very accurate in that assessment. Did that kind of hit on what you were asking about? And it is okay to
Yeah,
unmute and interrupt.
yeah.
Okay.
That sounds about good for me.
Okay. Yeah, so the way to think about some of these things is that when stress is low, we tend to think about these things as rational humans, and we reason things out. As the stress gets higher, then we revert more to a mammalian sort of brain that will look at options, but we're pre-programmed with that um, freeze, flight, or fight response. And that's really the order that it takes. As an early mammal, we would first freeze, because if you can't see me moving, you probably can't see me. And then the next one is to run away. And then the very last option is to fight. But then the next level down is the reptilian sort of brain. So it's very, very um, reflex oriented. But that's a good question, Ben. Thank you. Um, thank you. So here's where we're going to get into the really ugly part of this as far as things. I don't know if y'all have heard of the Diagnostic and Statistical Manual. This is what psychiatry and psychology uses to make their diagnoses. And they have a list of criteria for all of these things. So I've underlined some stuff. This is my emphasis, not theirs, but to try to point out a few things. First off, criterion A, and there's going to be a lot of these, okay? But exposure to real or threatened, and you can see the list there in the following ways. They were directly exposed, they witnessed it in person, they learned about it, and then there's indirect exposure, which is what we tend to have, okay? But notice that very last sentence there. It does not include watching it on TV or other media. So you have to have something from criteria A, okay, in your list of things. Criterion B, these are the intrusion symptoms. So this is recurrent or involuntary thoughts, nightmares, flashbacks, or other psychological distress on exposure to these things. And there is a physiologic reactivity. So blood pressure, heart rate, those things are up. So think about that startle response. Criterion C, avoidance, okay? So you do things to avoid these memories and to avoid other reminders. So this is where some, especially we have a lot of veterans that they just withdraw. They no longer have ties to family. They cut ties with friends, and they try to avoid things like going to 4th of July celebrations, those sort of things. So it's trying to keep those things from coming back up. Criteria D, negative alterations in mood. So, I like the second one there about I'm bad or the world is completely dangerous. Those are very distorted, okay? Most folks, especially most of the veterans, when they go into the military, that's not the way that they feel, but they have that distorted belief afterwards, okay? And they may blame themselves or others, or a negative emotional state, or the persistent inability to experience a positive emotion. So if you've known any veterans over a period of time, especially with these wars that we've had for the past 20 years, you know that there are some of them that they just don't have any happiness or anything. Nothing seems to be pleasing to them. So very, very difficult thing for these folks. Criteria E, alterations in arousal and reactivity. So here's that hypervigilance, they're irritable, they're self-destructive, they can't sleep. That seems to be a really, really common thing with this, is they have trouble sleeping. And then see what I meant about a long list of these things? We're all the way up to criterion H. So F is duration. That has to be there for more than 1 month, okay? and G, it's causing them problems. There are folks that frankly, they may look like they're okay. I'll use a word that we shouldn't use, crazy, but you know what? They're functional with their mental illness. And so, if they're still functional with those things, then that's not necessarily a bad thing. They may have figured a way to work with these things, but I throw that out there as an example. Okay. And then the last one, not attributable to substance use medications or other medical problems. And that's really where you and I come into this. When I see folks with psychiatric issues, one of the things that I always tell them is, I am not a psychiatrist. I'm the emergency physician. I'm here to look for medical reasons to explain why you're feeling the way that you're feeling. And that's my first job. So I'm going to do that. Then we'll end up getting you with the proper people so that they can talk to you about the other stuff. So any questions about the DSM criteria other than this is not going to be on a test anywhere other than they may ask you duration?
Dr. Phillips, I do have one.
Sure.
When it comes to the substance abuse side of it, why wouldn't that be used as a way to positively diagnose somebody with PTSD along with other symptoms, obviously?
Well, no, the difference, and that's a great question, and I'm glad that you ask it because that gives me a chance to explain this. So in other words, they're saying that that the alcohol or substance abuse is not the cause of the symptoms. So in other words, if somebody has these symptoms and they start using drugs and alcohol to try to cope with their symptoms, that's totally different than somebody that has all these symptoms because they were addicted to drugs and alcohol, and that led to the symptoms alone. Does that make sense? So which one came first, chicken or the egg?
Gotcha.
Okay, excellent question though. So I'm glad you asked that so that I can make that clear. Anything else? Now, after seeing DSM criteria, do you understand why mental health professionals sometimes are the way they are?
And they just came out with DSM-6.
Oh, great. Now I'm already behind. When I was in medical school, it was DSM-3. So let's talk about the mental status examination. First off, that's something that in emergency medicine across the spectrum, pre-hospital all the way into the ER towards the hospital, we don't really do that well. And it's more a matter of, it's a very detailed and very time-consuming sort of thing to get, but there are tools that you can use to get a modified mental status examination. We'll talk about the mini mental status examination in a second. But the big things that come out with PTSD on mental status: poor sleep, poor concentration, they're having the nightmares and the flashbacks, they're having guilt or negative emotions, and they have avoidance. Once again, we talked about the increased vigilance. So, these are things that as you're talking to somebody that potentially may have PTSD, that you probably want to ask them, so tell me, are you sleeping at all? Typically they're going to tell you, I only sleep 2 or 3 hours a night, or I don't really sleep. You may notice them during your evaluation having trouble concentrating and paying attention to what you're asking them. Guilt and negative emotions, those things typically just kind of come flying out. But these are some important points. Now, this is the mini mental status examination. If somebody wants to make an app that has this, it's easy to use. There is one on the App Store for Apple, and I downloaded it today, and I'm going, are you kidding me? You got an advertisement on every page. Which of course, spend another, $4 and they'll take those off of there. But, I don't know why it's not something that's easier to find. And I would think that actually my neuro toolkit, and that's the actual name of the app, which, by the way, I do highly recommend for the stroke scores. All of the stroke scores are in there, GCS, those sort of things. So it makes it easy for you to ask those questions. And especially if you're doing an IH stroke score, you can show them the pictures. It's got the words that they have to read, all of those things. But this is a mini mental status examination. It's not that difficult to do. I mean, we're asking a lot of these questions now. Can you tell me what year it is? What season is this? Day, date, simple stuff. Start big, work down to small. And then, some of these other things. Now, the app that I've downloaded for question 3, it actually gives you the objects for you to tell them. You can make up any 3 objects, but it will give you 3 objects there. And then some of these other things about, writing a sentence, and all this, those are a little more difficult for us in the field. But at the same time, if you get where this is part of your, I'm going to do this on psychiatric calls, it doesn't take that long to do. And especially if this is a great way to check and see if somebody really is competent to make a decision for themselves. If they're doing terrible on this examination, they probably should not be trying to make decisions on their own. And this could be a way for you to show law enforcement, hey, look, out of 3, he scored a 10. And this tells how they're thinking. And, usually they're going to take that into a little better strength as far as the evidence goes. So, it's something to consider. I think if you're looking to up your game to the next level, once you get out of paramedic school, this is a great way to do it because it's something that is easy to do and it's very easily replicated. So it's a very reliable examination. Any questions about the mental status evaluation? Sometimes I
Dr.
question my
Phillips,
own.
I do have a question about the MMSE actually. So when it comes to PTSD though, is this tool really all that effective in being able to, what would be the purpose in using this with PTSD? I guess if somebody's having other psychological symptoms attached to it as well, or some kind of crises?
No. First off, think about you yourself trying to count backwards from 100 by 7s if you're having difficulty concentrating. How about some of these other things, just being able to do some of these things. They may be dissociated, so they may not know what year it is. They may not know where they're at. And this is a simple way, and especially if you introduce it properly, it's a simple way to get this information without it being somewhat offensive. Sometimes people get offended when you start saying, well, do you know where you're at? What, do you think I'm crazy? If it's, okay, I'm going to do this thing called a mini mental status examination. It's just something that we do with people when they're sick sometimes. And so I just need to ask you some questions that are going to be kind of stupid, but please play along with me because the doctor's going to ask me about this. Blame it on me. Okay. Got big shoulders. I don't mind that. I would rather that you do the right thing for people and blame me for telling you to do something dumb. Okay. When I say me, I mean the ER doctor in general. Hey, the ER doctor is going to be upset if I don't ask you to spell world backwards. Okay. It's a stupid thing. He's like that, but at the same time, you do get into orientation questions that can play into dissociations, their concentration, their ability to do math, which subtracting 7 each time. And it's based on that 5 there is based on them doing 5 numbers backwards, all the way back to 65 there. So, are they able to recall short-term things? So you gave them 3 things to remember. You see that that's the 3rd and the 5th item. So, those are some of the things that do actually play a part in a potential PTSD. So, the mini mental status examination is actually from psychiatry. Neurology uses it as well. Then again, the neurology and psychiatry boards actually are certifying boards that are stuck together. So, they are so closely interrelated. So yeah, it does give you some information that will be useful even in PTSD. Good question, though. Anything else? And did that answer your question, Ben?
Sure.
Okay, I always want to be sure that I answered the question. If it's still not clear, please tell me, okay? Because I have a habit of not always being perfectly clear with things. Okay. So the physical examination. Now, this is one of those things that first off, once again, I told you, you're going to have to do history and physical on everybody every time that you see them. This is the career that you've chosen. And I don't care how far up in that career that you go, I still do history and physical on every patient that I see. Even if they can't talk to me, I still get a history and I do a physical examination. So what we're trying to detect, and once again, what I tell these people is, I'm here looking for a medical explanation for what is going on. And I don't think that you're crazy. I want to prove that there is something else causing this. And that usually gets a lot of compliance when you put it that way, is let's prove together that you're not crazy. Let's look for the medical reason. Now, labs other than a glucose, realistically, we're not going to be able to get, because we're talking about a complete blood count, a urine drug screen, thyroid stimulating hormone. Yeah, we got that one installed in the back of our ambulance last week. Vitamin B12 level, folate, and those are for anemias and also some other metabolic problems. CT scan and an MRI. Okay, I guess we could call the mobile stroke unit out and get a CT scan, but you get my point. Most of the testing is going to have to take place in a hospital. But you can do a detailed physical examination looking for evidence of trauma, physical trauma. That's really kind of what the physical exam comes down to. You may find medical things too. You may find a pneumonia. You may find somebody that has atrial fibrillation with RVR. Those are sometimes very valid medical reasons, and that may clue us in, especially the AFib or SVT, that their thyroid is out of whack. So, there are always things like that may crop up on a physical examination if you do a good physical, okay? And once again, I don't want to assume that somebody has a mental illness until I've proven that they don't have a physical illness. So treatment, really the main thing for us is going to be recognition and taking them to an appropriate treatment facility, not necessarily a facility and not necessarily someplace that they're going to be locked up. Okay. Just understand that all of these have very high emotions that are associated with them. And what we really want to tell them is, listen, I want to get you to the proper place where you can get the things done that are going to help you the most. That doesn't mean that they're necessarily going to lock anybody up, okay? If they do, that's only because they're concerned for your safety. And so, sometimes having a very frank discussion with people is a very good thing. Sometimes it's not, and I'll admit that. And so these are things that over years you're going to get to where you can kind of gauge a little better. Now, there's a thing called trauma-focused psychotherapy. Obviously, we're not doing psychotherapy in the back of the ambulance, okay? But this is part of the treatment for this. And here are some of the things that they will do with these folks. The eye movement desensitization is one that's actually showing a lot of promise. And I don't understand these things exactly, but just understand that there are some things out there besides throwing medicine at people. Now, all therapy has shown to shorten the course if it's somebody who will recover. However, long term, for most patients, it does not change that outcome. So what we're trying to do is give them a way of coping with the disabilities that they're going to have and trying to minimize the effects of those. Pharmacotherapy, yeah, unfortunately, we're raised in this generation, in this country, if you, well, y'all are not old enough to remember the old TV shows Friday night, when there was a competitor for Saturday Night Live with the pharmacist. Big one was just take a pill. So there are a lot of things here. Obviously, these are going to be way out of our range, other than sometimes Haldol as an antipsychotic if somebody is violent. But this is more talking on a long-term basis. I thought it was interesting using clonidine to reduce nightmares. I've seen it used for insomnia, but I didn't know that it worked in that manner as well, or prazosin for that matter. Trazodone does help with insomnia, and a lot of people take it for that reason. So the SSRIs, selective serotonin reuptake inhibitors, and selected norepinephrine reuptake inhibitors. We talked about why those may end up being not in the proper balance earlier. Any questions up to that point? I understand that, this is one of those lectures where, so much of it really doesn't apply to pre-hospital, but it's a recognition sort of thing. John, did you have a question?
Yeah, real quick. Just about the eye movement. What does that look like when it's desensitized?
You're asking the wrong person there.
Oh, sorry.
I'm
Okay.
lucky that I could pronounce it. No, I've
Yeah,
never
right.
seen it. I have talked to several veterans that they say that they have done that through the VA, or folks that have had some traumatic brain injuries will also sometimes have the same thing. It's not that uncommon for kids that have had concussions to sometimes have the eye motion training as part of the recovery for that. And in fact, for concussion, eye movement disorders is one of the big things that they look for to diagnose that. So there is crossover between those.
So
But
is it like
excellent question.
is it like a tracking problem? Like,
I believe that it's more one of those, when something happens, they will automatically start looking to those directions and in an anticipation, and that's kind of an anxiety provoking sort of thing. So I think it's more a matter of the desensitization. But once again, I have no clue. I've not
thank
seen
you.
it. I've only heard about it mostly with people with brain injury, and I know with the athletes, it's more of a retraining of them to not lose focus straight ahead.
Gotcha. All right. Thank you.
Sure. So differential diagnosis. So everything in medicine has a differential diagnosis, other things that it could be. Okay. So, and a lot of times I will throw out to patients, listen, I'm not saying that you're psychotic, just because you're seeing the snakes on the walls and the voices are telling you to do this and that. Let's look for some other things. Here's some medical reasons why you may have some of those things. Did you take too much Benadryl? But those, I always want to leave the door open for there to be something else. And so this is a list of some of the things that this could be besides PTSD. So acute stress, depression, adjustment disorders, anxiety, and once again, traumatic brain injury. So there are several other things that it may be. And if you talk to an internal medicine doctor, they're going to give you probably about 3 times that list. because, and we should also include medical things in there as well. So, for the most part, they're not going to have the chronicity that is needed. So they're not going to have the symptoms for a month or more, but it's something that we probably should kind of consider a little bit and be able to think about those things. Because if you don't think about it, you're never going to make the diagnosis. So prognosis. What we're hoping is that we can help them to cope better with stress, substance abuse, and those sort of things. But the big thing is their ability to stay compliant with the treatment. So that's really the main thing that's going to tell you what the prognosis is. 30% are said to recover spontaneously, and this is just some of the sources. There are other numbers that are thrown about as well. But 40% more improve with treatment. So fully, you can expect that probably 70% of folks will get some improvement. And if they have other comorbidities, that tends to worsen the prognosis. So some of the complications. Once again, common comorbidities tend to make this worse, but they also make the comorbidities worse. So the PTSD tends to exacerbate everything, and it's exacerbated by everything. But especially mood disorders, anxiety and panic disorders, neurologic, and there's the dementia that we were talking about. So people that have dementia may have some PTSD because they're reliving those events, and then the brain changes from the PTSD may induce dementia in them. Substance abuse is very high with this. And note there, over half of the men with PTSD abuse alcohol. And there's an increased risk of suicidal ideation and attempts. And I would say also completions, because the folks that have PTSD, they tend to use more lethal methods in their attempts. And once again, that higher risk of dementia, and that's due to the structural changes in the brain. So I thought that this was rather interesting. And so this is a slide all its own. We're going to shift a little bit away from our patients, and let's talk a little bit about ourselves. Okay. First responders in this category includes EMS, fire, police, and even military. So 80% of those will report some exposure to traumatic events in the course of their duties. Now, overall, the prevalence here, you notice, is highest for emergency medical service personnel. The lowest, and I thought this was interesting, and I saw another site that had some numbers that were very, very different for police, 4.7%. And I got questioning that, and they said that the main reason for that is that police officers, because of the deadly force, tend to have a lot more psychological screening. And so those people that are not as resilient tend to be weeded out early on. And so they don't stay in law enforcement. So I thought that was kind of interesting. I'm not proposing that we should start screening fire and EMS for resilience and mental health, but at the same time, realizing that we may be at a little higher risk, a lot higher risk, is something that we should do and we should acknowledge. And I thought it was interesting, 13.5% for other rescue teams. And I have a feeling that that's probably more because of the things that the rescue teams go for. I don't think that they're talking about somebody that's on the hazmat team or somebody that's necessarily on swift water, but I think that they're talking about disaster response rescue teams, because they tend to go into areas where the devastation is just off the scale, and they tend to end up on pulling bodies rather than rescuing survivors. So I noticed that that's a lot higher as well, but I think that that's the reason. I didn't find an exact cause. Now, the people that are symptomatic in the US are estimating approximately 400,000 first responders, and 10% worldwide in the first responder communities. That's a lot of people. And there's also the stigma and underreporting. And the main reason is you don't want to be judged by your peers, your supervisors. There is a very real possibility in some systems that you could be demoted or you could lose your job if they feel that you're not able to perform that duty. And then there's these other things as well. And the biggest thing tends to be even we don't know where we should go for treatment. Now, I'm going to tell you a true story about one of the technicians that I worked with when I was in the Air Force. I was an emergency physician in the Air Force. This was way before any of the wars. This was during a time of peace. She was one of our technicians, which means that she was trained as a paramedic, but they had additional duties and responsibilities that they could take care of in the emergency department as well, including they did all of our suturing except on the face. Well, one day, two of the technicians that were dating each other, which they shouldn't have been, but that's beside the point, they got a call from her saying, hey, I just wanted to see if y'all were coming over tonight. And the guy goes, well, yeah, we had planned on coming over. Is there a problem? No, I was just wanting to make sure that you were going to be there. Something's wrong. What's up? Nothing. Hung up the phone. So the sergeant went to his sergeant and said, I'm leaving. I've got to go and check on her. And so he went and checked on her and found her laying in a bathtub, and she had put two 14 gauge IVs and one in each AC and had lost over 2 units of blood. So I will say that at that particular time in the military, if you attempted suicide, you're pretty much guaranteed that you had just lost your entire career. And I don't know what was different, but for some reason, she actually was able to get treated medically and then counseling. And she came back and went on to become an independent duty med tech in Korea. So, I still use her as a shining example of it doesn't have to be that you lose everything when you admit that you've got something like this going on. I don't know what led to her diagnoses and those things. I don't know what her diagnoses are, and I don't want to know. It's none of my business. I was not the physician taking care of her, and so I don't want to know. If at some point we're at some kind of social function and she starts talking about it and wants to talk about it, okay, but just understand that there is the stigma associated with PTSD in our work. I stole this off of Wikipedia, but I think it's an excellent thing. Jane, I think this is something that we should probably send out to all the students as well. Every one of these experiences is going to be a rock, and you're going to carry that rock in your backpack until you unload it. And I'm guilty of having been carrying a heavy backpack for a long time. So, it's not something that any of us is immune to. So, unfortunately, I've known a lot of friends that have committed suicide because of this career. I know one in particular, he didn't commit suicide, at least not in a fast manner, but that I still credit with saving my life because I was one of the first responders that went to the Delta crash at DFW back in the late 80s. And one of my partners said, I'm going to stay and I'll pull bodies. I have to do this. Send Phillips to the hospital. And I got sent with the ambulance to the hospital to help out there. But Trey Hanrahan, I'm convinced, saved my life. Unfortunately, he ended up abusing drugs and alcohol heavily after that and eventually died of hepatitis. So, remember those that are behind you, remember those that are ahead of you, because you're going to need each other. We also lost quite a few of our paramedics to other professions as a result of that. Some went on to become law enforcement, some fire, but we lost a lot of really good people as a result of that experience. Here is especially that first item up there. If you want a very detailed description of this, that is probably one of the best as far as just PTSD in general. A lot of these other things I actually got from the third, which is the Tug McGraw org, and his resources for first responders. And they do a lot of work with traumatic brain injury and other groups as well. So I really think that that middle one there, when a child dies, at some point, we all will have a loss of a child that we respond to. And it's good to have that as information that you can contact them. You know, all of these websites are just at their websites. There's no way that anybody is going to come and call you to the boss's office and say, hey, I saw that you went on that website. That's not going to happen. But just realize that if you're having some of these symptoms, you need to get some help for it. And there is no problem with that. So with that, that's the end of all that. Are there any questions?
I do have one. Maybe you can direct me to a better resource, and this may be a little bit off the topic or a little bit too much of a backstory, and I'm sorry for that. But recently I heard about one that happened in a clothing store, kind of like a Dillard's, where a young lady was approached, and they had touched her on her arm to get her attention. It sent her into a massive PTSD episode. And what got me wanting to know more about it was that there was a sales associate there at the time who had a brother who suffered from PTSD through the military and immediately recognized the signs and did certain things like got on the ground, started using certain safe words, started using certain directions until they got that lady's husband on the phone, who then knew through counseling, like that additional safe words, additional statements that they just kept repeating over and over and over to her until she was able to come back to where she was actually at. And it made me wonder, just like that's it. I was kind of curious to find a resource that talked about, I guess, what they go through with counseling or something where we can be more aware of, hey, if you do this and you think it is this, here's safe words, or here's how most of them get approached to try to bring them back into that.
I think if that's something that you really have a huge interest in, the first organization that I think of is Code Green.
Okay.
And Code Green is for first responders. But I think that if that's something that you're really interested in, they can either direct you to the proper resource, or they may also say, would you like to be trained to be one of our counselors to help folks? And one of our scribes at the hospital that I work at, she is in the midst of doing training to be a phone counselor for kids, especially kids that are whatever, the gay is the easiest way for me to say it, but along that whole spectrum of folks. And she said, I was one of those kids in high school that I thought about killing myself every day. And she goes, this group helped me through that. I want to get back. And so she was going through their training online. And I'm sure some of those things are things that would come up during that sort of training. But if that's not something that you have an interest in, I'm sure that they can direct you to the proper resource to try to find that information. That's 500 level stuff for our purposes here. And I don't know it either. So, I'll be glad if anybody has never told you, I am very quick to tell you if I don't know something. But excellent question. I appreciate that. I really do. Makes me want to kind of look into it. John, Ben?
All right, I'll ask a question real quick. I don't know if you actually had this at the beginning, but I was just curious if age has any effect on developing PTSD, like if you're older or younger, if you're more likely to develop it, or if
That's
all around.
that's a very good question. And the I would tell you that I never saw anything that said that age is a factor. And I think that probably the biggest proof of that is, that children can have this and it can go all the way through adulthood. Now, I think that obviously, depending on the threat or those sort of things, the maturity level of the patient may make it that they're better at handling that particular stressor. And obviously, people that, just taking law enforcement versus, EMS, the people that are trained for those sort of
Right.
situations, they tend to do better with them. And so I think that probably what you find is that as the age of the trauma goes higher, the chances of developing PTSD from that are lower. Now, I know
Gotcha.
that when my trauma happened, I was 21. And, that was also during a time when we were not supposed to say things like that. And,
Right.
that truly was a good way to lose your job. And, one of the EMS supervisors for MedStar, I remember hearing about him walking into one of the stations and putting a gun to his head. He didn't pull the trigger, thank God, but he was basically escorted out as a result of that. And so, and I hate to see that because these are good people. So, but I believe that the training level tends to help with those sort of things. But then you look at the military, God knows they're trained to see those things, but there's no way that they can ever adequately be prepared. Is there any way that we can adequately train our people? And I'll use an example of a call that did happen here in Parker County, to go to a home where a mother has hung her 3 children in a closet, killing all 3 of them. There's no way that you can prepare for that.
Right.
So, it's a matter of, in those cases, my first call is to dispatch and say, okay, where are they right now? I need to talk to them.
Right. Awesome.
But
Thank
that
you.
is an excellent question, John.
Yeah. Thank you, Dr. Phillips, for this lecture. It's been
Ben,
really useful for me.
you're very welcome. Very welcome. I think everyone has definitely participated in that, Jane.
I think they have too. This
We've
was a
had
great
some,
lecture. Thank you so
had some,
much.
yeah,
And I'm in the
yeah. I'll tell
process
you,
of
this is one of the
typing.
harder ones to put together.
Yeah, and I like that one thing that you wanted me to put out there. I was in the process of having to retype it, but putting it on our forums for people to have a little tidbit of a thought about that. So appreciate that.
Well, and if you want, I'll send you a PDF of the lectures. That way you can pull that stuff out.
Sure, sounds good. All right, everybody.
Okay.
Thank you for coming tonight. Enjoyed it. Ryan, I've already posted your grade for Kathy, so she didn't have to worry about that. And Ben and John, I've posted your grades as well. Good night, everybody.
Thank you, Dr. Phillips.
Good night. Thank you.